good evening friends, Pradeep Pendyala, your buddy. Today I am going to talk about ATLS, Advanced Trauma Life Support. Before I start talking about ATLS, let me tell you how it started. It started initially in the United States when James K. Steiner, an orthopedic surgeon, was piloting a light aircraft which crashed into a field in Nebraska. His wife Charlene was killed instantly and 3 of his 4 children were critically injured. He carried out the initial triage of his children at the crash site. Dr. Steiner had to flag down a car to transport him to the nearest hospital. Upon arrival, he found out that the hospital didn't have enough emergency care, and he felt what he did at the site of the accident was much better than what actually happened in the hospital. So when he returned to Lincoln, Dr. Steiner declared, "When I can provide better care in the field with limited resources than what my children and I received at the primary care facility, there's something wrong with the system and the system has to be changed." And this is how he started developing a system and saving lives in medical trauma situation. And that's how advanced trauma life support was developed, and this was accepted by the American College of Surgeons. I'm sure this was a very, very interesting history which very few people know about it. Whenever such thing happens, advanced trauma happens, you have to have primary survey, secondary survey and tertiary survey. In primary survey, what you have to see is ABCD. Airway maintenance, cervical spine stabilization is the first step. After that follows ABCD. The first stage of primary survey is to assess the airway. If the patient is able to talk, the airway is likely to be clear. If the patient is unconscious, he or she may not be able to maintain his own airway. The airway can be opened using a chin lift or jaw thrust. Airway adjuncts may be required. If the airway is blocked by blood or vomitus, the fluid must be cleaned out by the patient's mouth, out of the patient's mouth with the help of suctioning instruments. In case of obstruction, you have to pass an endotracheal tube. Second, ABCD, breathing and ventilation. The chest must be examined by inspection, palpation, percussion and auscultation. There could be subcutaneous emphysema and tracheal deviation must be identified if present. The aim is to identify and manage 6 life-threatening thoracic conditions. They are airway obstruction, tension pneumothorax, massive hemothorax, open pneumothorax, flail chest and pulmonary contusion and cardiac tamponade. Flail chest and tracheal deviation, penetrating injuries and bruising can be recognized by inspection. Subcutaneous emphysema can be recognized by palpation. And tension pneumothorax and hemothorax can be recognized by percussion and auscultation. Coming to C, circulation with bleeding control. Hemorrhage is the predominant cause of preventable post-injury deaths. Hypovolemic shock is caused by significant blood loss. 2 large bore intravenous lines are established and crystalloid solution may be given. The person does not respond to this. Type specific blood or O negative, if this is not available, should be given. External bleeding is controlled by direct pressure. Occult blood loss may be into the chest, abdomen, pelvis or into the long bones. Now D is disability or neurologic assessment. During the primary survey, a basic neurological assessment is made known as by the mnemonic AVPU. A stands for alert, V for verbal stimuli, P for painful stimuli, response, and U for unresponsive. A more detailed and rapid neurological evaluation is performed at the end of primary survey. This establishes the patient's level of consciousness, pupil size, reaction, lateralizing signs, and spinal cord injury. The Glasgow Coma scale is a quick method to determine the level of consciousness and is predictive of patient outcome. If not done in the primary survey, it should be performed as part of the more detailed neurologic examination, the secondary survey. An altered level of consciousness indicates the need for immediate re-evaluation of the patient's oxygenation, ventilation, and perfusion status. Hypoglycemia and drugs, including alcohol, may be the influencing factor for the unconsciousness. If these are excluded, changes in the level of consciousness should be considered to be due to traumatic brain injury until proven otherwise. E in the primary surveys is nothing but exposure and environmental control. The patient should be completely undressed, usually by cutting off the garments. It is imperative to cover the patient with warm blankets to prevent hypothermia. In emergency department, intravenous fluid should be warmed and the warm environment maintained. Patient privacy should be maintained. Now coming to secondary survey. When the primary survey is completed, resuscitation efforts are well established and the vital signs are normalizing. The secondary survey can begin. The secondary survey is a head-to-toe evaluation of the trauma patient, including a complete history and the physical examination, including the reassessment of all vital signs. Each region of the body must be fully examined. X-rays indicated by examinations are obtained if at any time during the secondary survey and the patient deteriorates. Another primary survey should be carried out if the patient deteriorates and there could be potential threat to the life. The person should be removed from the hard spine board and placed on a firm mattress. Why? The skin breakdown would take place and pain while the firm mattress provides equivalent stability for the potential spinal fracture. Now coming to tertiary survey, a careful and complete examination followed by serial assessment help recognize missed injuries and related problems. Allowing a definitive care management, the rate of delayed diagnosis may be as high as 10%. So this is that. I'm sure this was very, very informative and you have understood what is it all about. And in Army, we have BALTS, nothing but it's Battlefield Advanced Trauma Life Support. So it's nothing but the same thing in different format. So I'm sure this was very informative. Thanks for patient listening. This is Colonel Pradeep Pendyala, Professor of Anesthesiology at ASRAM Medical College, University of India. Until next time, take care. Bye-bye.